Chest pain after the resolution of acute coronary syndrome, ACS, is not uncommon and can arise from various causes. It's important to differentiate between cardiac and non-cardiac origins to guide management effectively. Here are some potential causes. 1. Cardiac causes. Incomplete revascularization, residual ischemia due to partially treated coronary arteries. Coronary artery spasm, vasospasm causing episodic pain, often without significant stenosis. Pericarditis, post-MI pericarditis, Dressler syndrome, can occur days to weeks after the event. Stent complications, restenosis or thrombosis of the stented artery. Heart failure, pain related to volume overload or pulmonary congestion. 2. Non-cardiac causes, musculoskeletal pain due to prolonged immobilization, CPR, or thoracotomy during surgical interventions. Gastrointestinal causes, gastroesophageal reflux disease, GERD, peptic ulcers, or esophageal spasms. Anxiety or stress, post-ACS psychological stress often presents as chest discomfort. 3. Red flags requiring immediate attention, new or worsening chest pain with radiation to the jaw or arm. Associated symptoms like shortness of breath, diaphoresis, or palpitations. Evidence of hemodynamic instability or ECG changes. Management approach. Clinical evaluation, detailed history and physical examination. Investigations, ECG and troponin levels to rule out recurrent ischemia. Echocardiogram to assess cardiac function and complications. Stress testing or coronary angiography if ischemia is suspected. Symptom-specific treatment. Ischemic pain. Optimize antianginal therapy, e.g. nitrates, beta blockers. Pericarditis, NSAIDs and colchicine. GERD, proton pump inhibitors. Anxiety, psychological support, and/or anxiolytics. Close follow-up is essential to prevent complications and ensure optimal recovery. Post-acute coronary syndrome, ACS, psychological stress, commonly referred to as post-cardiac event stress, is a frequent but under-recognized condition. It encompasses emotional, cognitive, and behavioral reactions to the life-threatening nature of ACS. Below are key aspects. 1. Clinical manifestations. Anxiety disorders, generalized anxiety about health and future cardiac events. Panic attacks with chest tightness, palpitations, and breathlessness mimicking angina. Depression, feelings of hopelessness, sadness, or lack of motivation. Poor adherence to medications or lifestyle modifications. Post-traumatic stress disorder, PTSD. Re-experiencing the ACS event, flashbacks, nightmares. Avoidance of reminders, e.g., avoiding exercise out of fear it may trigger an event. Hypervigilance or exaggerated health concerns. Health anxiety, cardiac neurosis. Persistent fear of a recurrent event despite reassurance and normal evaluations. 2. Risk factors. Demographic factors. Younger age, female gender. Pre-existing conditions. History of anxiety, depression, or PTSD. Event-related factors. Sudden or severe onset of ACS. Complications during treatment, e.g., cardiogenic shock, prolonged ICU stay. Social stressors. Lack of support systems or financial concerns. 3. Pathophysiology, neuroendocrine dysregulation. Elevated cortisol and catecholamine levels due to stress can exacerbate cardiac risks. Heart-brain interaction. Stress activates the sympathetic nervous system, increasing heart rate and blood pressure, which can provoke ischemic episodes. 4. Diagnosis. Use of validated screening tools such as PHQ-9 for depression, GAD-7 for anxiety, impact of events scale for PTSD. Holistic evaluation. Consider physical and psychological symptoms together. 5. Management, psychological interventions, cognitive behavioral therapy, CBT, focuses on restructuring irrational fears and developing coping mechanisms. Stress management programs includes relaxation techniques, mindfulness, or meditation. Pharmacological treatment, SSRIs, e.g. sertraline, citalopram for anxiety and depression. Beta blockers can help alleviate somatic symptoms like palpitations. Cardiac rehabilitation combines exercise, education, and emotional support. Reinforces confidence in physical abilities. Social support, family involvement in recovery planning, participation in support groups or peer networks. Lifestyle modifications, healthy diet, regular physical activity, and sufficient sleep. 6. Prognosis. When untreated, psychological stress after ACS can increase the risk of recurrent cardiac events, impair adherence to treatment and rehabilitation programs, reduce overall quality of life. Early detection and treatment improve outcomes, reducing the burden of both psychological and cardiac complications. Effective management of post-ACS psychological stress requires a multidisciplinary approach involving cardiologists, psychologists, and rehabilitation specialists.